So good evening and welcome to the first webinar for the Australian Centre for Value-Based Healthcare. My name's Lisa Roby. I'm the Engagement and Business Director at the Australian Healthcare and Hospitals Association, and it's my pleasure to be your host tonight. Before we get underway, I'd first like to acknowledge and pay my respects to the traditional owners of the lands on which we meet, wherever we may be tonight, and to pay our respects to elders past and present. I'd also like to extend that respect to any Aboriginal and Torres Strait Islander people who are joining us here tonight. Tonight, we are joined all the way from the United Kingdom by Rob McGough, who's a partner at Hill Dickinson. Rob focuses on the health sector legal, commercial and contractual issues for the NHS and public sector organisations, as well as independent health providers from both the UK and internationally. He has a particular focus on value-based contracting and procurement and has supported the development of pioneering value-based approaches to healthcare procurement and contracts, which is what he'll be discussing with us tonight. Now, Rob has agreed to take questions throughout the webinar tonight. So please, there's at the bottom of your screens, you'll see a Q&A section. You're able to ask questions there and we will work on answering them as we're able. So, housekeeping out of the way, I would like to once again thank Rob for taking the time to join us and pass over, say good morning and welcome to Rob McGough.
Thank you, Lisa. Can everyone hear me okay? Can you hear me all right? It's a pleasure to be with you all this morning as it is here, or this evening as it is for you, and I appreciate that obviously it's quite late for some of you as well, but I'm just going to try and get my slides up if I can share that with you. So, Lisa, I don't know if people can see my video.
We can certainly see your slides, Rob.
Perfect. Thank you very much, Lisa. So, without further ado, thank you very much for the introduction. What I'm going to do is I'm going to focus to the session this evening on how procurement and contracting can become key mechanisms in moving towards more of a value-based approach. How you can start to rewire a system and look to incentivize that different approach. And the main examples I'm going to be focusing on are going to be from the NHS, though some are going to be tapping into the experience that we've had from Europe, from the Netherlands, from Sweden, Wales, and wider afield. But the NHS obviously is quite a good example. It's a state-funded system, but it still has a market in there between payers, commissioners and providers, and there's an element of competition in there as well, so it's quite a dynamic potential healthcare system. But the NHS, along with most other European healthcare systems, has been predominantly working on fee-for-service, block contracts, payment for results and processes for a number of years, and moving away from that into looking at more of outcomes and then trying to move towards value, we've started to see a shift over the course of the last 3 to 4 years into something which is more outcomes and value based. And it's driving a move away from some of the traditional procurement and contracting processes that we've actually been seeing in the UK, starting to move away from some of the traditional organisational silos that have developed around how the healthcare system works, and looking to have a new approach to greater collaboration, looking at risk shares, gain shares across a number of different players in the system. And so it's created quite an interesting dynamic. So what I'll look to run through with you all this evening is the challenge. I think the challenge is quite clear as to why we want to be changing. Looking at levers within the system, and this is really in terms of how can you start to gear a system towards moving to more of a value-based approach. What can you actually pull? What can change the system? I'm going to specifically then look at procuring for value and outcomes, because public procurement rules and how we actually purchase both products and services in healthcare has quite a key role to play in terms of a move to value-based healthcare. Then moving on to the actual contracting mechanisms, I'd like to give you a quick case study as well around Lambeth, which is something which we've worked on, a project on mental health services, where more of a value-based approach was adopted across a healthcare system. So from that perspective, I would like to pick up with that and then questions and discussion as we go through. So without further ado, looking at the challenge, well, this is a quote from Professor Mike Richards. He's actually was at that time leading the CQC, which is the Care Quality Commission, who were looking at the quality, looking at the state of the NHS system. And it was a quote that was used a couple of years back now as part of the 5-year forward view for the NHS, where as a major public document, we started to realise that actually the way that healthcare was being procured, commissioned, the way that healthcare was being delivered was not going to become sustainable, because the systems and structures within NHS for health and social care were not sustainable in terms of the finances and in terms of where the workforce and everything else was leading. So what was being picked up by the national policy at this point was that greater integration of care can actually start to enhance the value we get in terms of patient experience, looking at outcomes, and looking at better use of resources. And the output of this was that really health and social care need to work more closely to sustain and enhance this and to coordinate the delivery of care better. Now, what this requires and what has been increasingly picked up is that there needs to be more innovative approaches to governance and leadership when we're talking about large numbers of organisations coming together across primary care, community services, acute services, and some of the more specialised services, and looking at the data and the benchmarking, how we actually get the information around that and how we fund it as well. Now, when you start looking at those dynamics as the ways that you want to start changing the system, then contracting and procurement, I believe, become key elements into this. So this is just a slide really taken from the King's Fund, a think tank in the UK, around where the funding has clearly gone within the NHS. And without dwelling on it into too much detail, what it clearly shows is that the funding gap in terms of the way that healthcare services are being provided at the moment within the NHS show that even with additional funding that's been promised by the government, there's still a huge potential gap in terms of an ageing population with increasing demands, increasing issues around long-term conditions. This is being exacerbated by the fact that we have a large workforce crisis at the moment as well, in terms of shortage of doctors, nurses, not helped, I have to say, by Brexit, but that's hopefully the only time I'm going to mention Brexit this morning. The indicators on quality are also, this is the thing really, when we start looking at the disparity and if you like, variation on outcomes, what started to happen across the NHS is, as this squeeze has happened with the way that we're commissioning on a process and an input basis at the moment, what we're starting to see is that effectively the quality targets are starting to be missed in a large number of areas around the country, and that's increasing the pressure on the system. So working in Europe, working in areas such as the Netherlands and Sweden, we're also starting to see the same impact, is that they're doing all of their population demographics and they're seeing similar increases potentially in their healthcare budget, and are all starting to think, well, actually, from this perspective, we need to start changing. We need to start looking at how we're paying for this and how we're working in a different way. Now, from an NHS perspective, this slide is really just to demonstrate it's a complex landscape, and this is where the siloed working has tended to come from, where we have hospitals, mental health units, community services, all separate organisations with separate budgets being commissioned separately, GPs, dentists, specialised services. And that's before you even start looking at the preventative services around public health, which are again commissioned separately, and then social care, the ageing care for the population, which is delivered separately through our local authorities. And that means that there's a number of different levers, there's a number of different factors that come into this, but it creates a challenge in coordinating that and looking at the value that we're actually generating for patients and the population in a wider context. So what are the levers then that I think within the system? And this is a slide based on the NHS, but I think it's broadly transferable to international examples that we've seen as well. And there's a number of different factors and levers that start to come into play here. First is around obviously data, and you'll hear lots at the moment around how data is being used, better data around outcomes, around patient reported outcomes as well. Starting to get that one version of the truth as to where the issues are within the system, what the problems are we want to start fixing. Within the NHS, we also have National Institute for Health Clinical Excellence, which looks at the quality, making sure that the quality of services is acceptable and that new innovations are acceptable. What we've started to see over the last couple of years, if you think back to my previous slide, is a consolidation of providers, commissioners coming together, different organisations, trying to create more integrated architecture, if you like, for how the system should work. So there's the STPs I mentioned there, Sustainability Transformation Partnerships, integrated care systems, and integrated care providers. Integrated care is very much a buzzword in the NHS, in the same way that accountable care has become very much the buzzword across the US systems. And it's a similar concept in terms of what we're looking at is, can we actually get organisations to think together, looking across the wider spectrum of care pathways and actually the wider costs and how the delivery works across a number of different organisations simultaneously. And when you start taking those structures, we're then looking at the financial. Now, financial obviously is a key driver, will become a key driver for contracting and procurement. Now, payment by results is a system that's been operating in the UK for a number of years around working to set costs for set processes, for set procedures. That has tended to be moved away from in the last couple of years. I'll come on to that in more detail later. And we're seeing a lot more in terms of aligned incentives or block contracts, which effectively means if I'm a provider, I'm paid £5 million to provide a certain service, and if the cost of that is too much or too less, well, that's down to me. You're just effectively given a block budget and told to manage it within that. Now, we have had some outcome frameworks introduced, but they've been very minimal. So quality and outcomes framework for primary care has been a very small and diffuse amount of outcome measures, not really changing in or incentivizing behaviors. Sequence commissioning for quality and innovation, again, looking at outcome measures, but only 1-2% of a contract, and therefore not really driving behaviors of providers. The last two levers on this slide are procurement, obviously separating purchasers and providers, and then the forms of contract. And there's a number of different forms of contract which are available in the NHS and that we see used internationally as well, which make this quite an interesting dynamic. And I'll come on to those obviously as we move forward. So how do we start procuring for value and outcomes? What does that actually mean? What are we talking about when we start getting down to that? Well, obviously, in redefining healthcare, going back to Michael Porter, defining value in healthcare, outcomes that matter to patients divided by the costs that you need to achieve those outcomes. And it sounds relatively simple and straightforward, but finding the most effective means then for measuring the healthcare delivery, and then how do you actually build that into the way that you're actually purchasing for services, or you're purchasing for products as well. So how do we get to that wider, more holistic perspective using that equation? Now, what we've seen, both in the NHS and internationally, tends to be that when we look at procurement, where the procurement teams are set up and they're working on almost a siloed basis, what they tend to find when they're going through public procurement processes is that most of the decisions are determined on the basis of price. Price is very much the key determinant in decisions that are being made by organisations. And when organisations are working in a siloed way, that means that each individual is taking their own decision on the basis of the cost to them, which doesn't produce obviously value and actually creates an issue. Now, that does create issues. It drives the market in a particular way. Some commentators would suggest it drives out innovation and it drives out smaller providers and leads to unsustainable state of various products. And a number of the larger pharmaceutical and medical device producers have also started to talk very clearly along those lines and say that they want to be moving as well onto a value-based approach for the procurement of their products, which is interesting because obviously then from the point of view of our providers and our public sector here, they then think, well, they would say that, wouldn't they? They think they're going to make more money through that. So there's an interesting dynamic there in terms of almost a political discussion that's going on around the shift towards why we need to move to value. But if we take some of the detail of that apart, there's a clear move away from a focus on price. Now, the way that the regulations, the European regulations and directive works, it focuses and emphasizes value. So we're being told to look at the most economically advantageous. Now, that means that procurement teams need to think differently. They need to think, well, actually, it's not just the best price, but what's the most economically advantageous? And that moves to more of that value equation, the Porter value equation. Now, the procurement regulations, the law, as that's transposed across Europe, is then giving you much more support at looking at value. And I'll give you a couple of examples of where that's actually taken place. And then also rewarding the suppliers who make more investment into the better outcomes that you want, including patient-defined outcomes. So changing the processes, looking at the procurement process and saying, how can we make this work better for a value-based approach? So what we tend to find at the moment is a lot of the issues within procurement tend to come from procurement not being aligned with clinical, not having that wider whole system cost view. So, for example, in Yorkshire, what we had was a procurement process for surgical gloves, whereby consultants chosen the glove type of surgical gloves they wanted to use. The procurement team went and made a procurement saving of £50,000 by going for a different provider. Now, they went out through the normal framework and it was decided on the basis of cost. One problem with that was that these gloves weren't as good quality and didn't work as well as the previous gloves that the consultants had been using, and they tended to rip, and they tended to rip at awkward times. So that meant that the consultants were having to scrub out of operations, coming back in, and the consultants ended up double gloving for this, and obviously caused delays in process and cost. So additional cost caused by that particular procurement saving was then spread and shared out in another area, but it wasn't particularly visible because they weren't thinking around the whole cost of care. I think that's one of the things where we're starting to see the shift, where you having procurement on a value-based approach leads to you being able to actually look at it in a slightly different way. And this is an example really of a type of process where we start looking at value and determining it through outcomes throughout the entire approach. So what we'd look at for the start is starting by determining what your outcomes are. What is it that we think what's the problem we're trying to fix? What's the outcomes we really want to see from this? Now, the market engagement process is quite important here because under the procurement rules, we're allowed to go out and explain to the providers, this is what we're looking to do, this is how we want it to work. Now, that's important because we're going to be asking providers to work differently around this. We're going to be asking them potentially to find new collaborations, new way of working, new way of sharing and being measured financially. So having that time building in that market engagement is very important as part of this value-based approach. We then move on to that procurement process, that evaluation, and this is where it becomes quite different to some of the evaluation processes that we've seen previously, where we start to look at, do we build in site visits, product tests, looking through the existing data, defining the price quality ratio in a way that actually shows that we're bringing value out from this. Now, what we haven't seen in the past as much is actually assigning financial values to those outcomes. So you can compare apples with apples, if you like, in terms of, well, how much value are we going to put onto the quality of those gloves, particularly, as opposed to how much value we're putting on the price that we're paying per unit, and then measuring those two together as part of one equation when you come out, so that you can look at, well, what's the total cost of delivery of care if we choose this particular product over that one, or if we choose that particular service provider over another one. So that's the different dynamic which brings through the process. And then that means what we want to do is start to reward the suppliers who make more investment into the better outcomes that we want. Now, a really good example of this is the Karolinska Hospital in Sweden, whereby they went out for their imaging services, and rather than just saying, well, we want someone who's going to provide us with scanners and with the technical equipment, they said that we want to go for a long-term partnering arrangement. We want to look at the outcomes. We want better outcomes from the services we're providing to be driven by the imaging equipment. So what they eventually got is a contract with Philips around an innovation centre, where they were getting training on the equipment, they were getting best practice from it to ensure they could use the equipment to the fullest extent, access to test bed for new developments, and also shared risk and investment from Philips in terms of how they were working together. So effectively what they did through the procurement was to go out and look for something very different and award a contract to a supplier who was going to make the kind of investment into the better outcomes that they were really looking for. And then how are we tracking and measuring the outcomes in the real world during the phase? Now, there's two ways that I've suggested here that I've seen utilised in practice both in the UK and internationally. And one is that you evidence the actual improvements during the procurement process. So during the assessment, there's an evaluation. As an example I give you there in Norway, I'll give you in a bit more detail later. So you look at how it actually works in practice in a number of different scenarios. Or you have an outcome focus in the contracts and you assess the willingness to participate and risk share in the achievement of outcomes as well. And I'll give you a specific example from Canada in the next couple of slides on that as well. So using those methods, you can bring a much greater focus on how you're actually procuring to actually assess and achieve these outcomes. Now, what does that start to look like in practice? Well, here's one I made earlier. Here's one that we started to develop when we were working with NHS Wales around cataracts. So we took effectively a suite of outcomes that ICHOM, International Consortium for Health Outcome Measures, had developed, around how cataract processes would work. And then we started to work through, well, actually, how would we build in assessment of these in the procurement process? And then how does that then flow into the contract? So not just having a full value-based process and starting to get the data around where the value is in the system, but how do we incentivize everybody to work in the same way towards delivering that value? So building, if you like, the procurement and the contract side along with the assessment of what the outcomes are. And that then flows into this example here from Norway, which was patient feedback used as a criteria by the HINAS, which I won't try and pronounce for you, but it relates to IV catheters. And the issue with these particular catheters was that they'd had very poor patient experience. Effectively, they'd had a previous tender which had been awarded on cost. The products hadn't proved to be very good or very durable. Patients were reporting pain, high levels of pain. Nurses were saying it was very hard to actually fit the catheters, and they were snapping, and it was causing issues and potential injuries as well. So there was a lot of negative feedback. So they decided to look at it in a different way moving forward. So what they said is, well, actually, we want to look at the outcomes. We want to look at the full value as to what we're getting here rather than just the cost. So low levels of patient-reported pain was an award criteria for their procurement process, as well as other patient-focused aspects such as ease of use, safety. They wanted to see really how the product would actually work in practice. They built in a 2-month evaluation period, testing the products in the hospitals, testing them with staff, testing them with patients, scoring them then after the use in multiple settings as part of the evaluation process to determine, well, which of these products is actually really going to give us the best value in terms of not just being the cheapest, but the one which actually is going to work best and is going to work best with staff and work best with patients. Now, they awarded on the basis of the cost and qualitative factors that I've just mentioned, and they awarded to the provider who was, I think it was the third or fourth most expensive one. And obviously, those of you who are familiar with procurement will know that that invariably gives rise to a challenge. So the process here was then challenged on the basis that they've made a subjective award, and you can't possibly say that patients and staff scoring it in these settings is a fair way of actually assessing an evaluation for a procurement process. That challenge was rejected and the contract award was upheld. And it demonstrated again, certainly from a European perspective, that we can start to use these types of criteria and value-based criteria in our assessment for procurement processes. Second example here is slightly different in terms of its using outcomes in terms of sharing risk. And this comes into cardiac resynchronization devices, pacemakers, where in Canada, they'd had previous experience issues over the life cycle of these devices. And obviously, as all of you can appreciate, where these devices deplete, if the battery depletes, then surgery that is required to replace them. There can be complications, hospital stays and costs associated with that for the system. And also from a patient perspective, obviously having to keep on going back into hospital to have a new device fitted or a change to the device is not particularly an outcome that a patient is looking for. So from this perspective, they went through from a procurement process and said, well, what we want is the suppliers to work with us on this. They need to start telling us how long they think their devices are going to work in various scenarios, in various conditions. But the problem that they have is then in clinical data terms, they didn't have the data at that point as they were going through the procurement process, the providers, to support the assertions that they were making, because a lot of the devices had not yet reached the end of their life cycle, so they weren't entirely clear of that. So effectively, what they wanted to do was go with providers who are willing to go at risk in terms of what their device could do, how their device could work, and the value that they were going to get from it. So this then meant that if the device required replacement prior to the stated period, the provider would be paying for that replacement surgery. So the driver then, obviously the providers, to tender with a realistic life cycle prediction and allow the payer then, the commissioner, to assess against those patient outcomes. So effectively using the financial side to swing that through because the data wasn't available for that, but making it clear that they wanted to see value and they wanted to see outcomes through. And the Canadian system is one that's certainly, I think, one of the foremost systems that I've seen internationally in terms of adopting more of a value-based approach in the procurement exercises and also in their contracting. So if I turn to contracting, now health and care services provided to individuals and populations are currently arranged through a series of different contracts in different forms. And internationally, you see this, that there doesn't tend to be one standard form. There tends to be lots of different forms between lots of different siloed organisations, and there aren't really very many interlocking collaborative contractual arrangements. So what we see in the NHS, for example, you see NHSs and council bodies awarding contracts for primary care, very separate, different contracts. There is an NHS standard contract, but it differs depending upon which organisation that you want to work with. So community NHS services will still look different to public health, social care services. So what we have from a legal perspective is a complex set of separate contracts, all looking rather different, with a lack of coordination, which makes communication between providers, makes working across a pathway, working across a chain of different organisations quite difficult. Can lead to complex funding streams, lead to duplication, and it can make it more difficult and having a loss of focus effectively around the needs of the person, the patient, as they start moving through the pathway, as their care is actually handled in different ways. Now, as this affects, you can see how that can start to adversely affect how the services work together and how people start to effectively fall within the cracks between different services. So what does contracting for value start to mean then? Well, what I'm saying there is that's the current process. Current process is fairly siloed in terms of how we work with healthcare providers, in terms of providers of services and providers of products. We pay for procedures, we pay for results, we pay for processes, and that's what we focus on. We're focusing on price within that. So that's more of a traditional approach to contracting. What I'm thinking around when I'm talking around value-based contracting is a much more collaborative version of that. What we start to say is, well, we want to measure outputs. We want to measure outcomes of what we're actually doing here, rather than looking purely at the processes. And you'll see when we move on to some of the more detailed examples, and potentially a combination of both those inputs, processes, and outputs and outcomes is really where we're going to start to get to when we want to get and identify what the value actually is. But rewarding collaborations across a number of players in the system, and rewarding providers who are delivering the services and delivering the outcomes that we want to see. And so, to give you an example, really, if you want to measure inputs, in a lot of contracts, say for ambulance services, you may well have a contract which states that a certain number of ambulances have to be provided and available at a certain location at all times. What we then see, if we say, well, actually, no, we want to move to more of an output-based approach, we actually say, well, the outcome we want to see is that patients are achieving the right transport options for them within the right period of time. And so we're measuring that rather than the actual inputs of the number of ambulances, which frees the providers up to look at the model of provision and say, well, actually, if we want to provide it in a very different way or use non-emergency patient transport services or a different route, we're open to doing that. We're not actually held by an input-based contract to doing it in a particular way. And so I think value-based contracting is potentially much more collaborative, but it also does give providers much greater freedom as to how they could actually provide those services. So where should you start? Well, here's a diagram from processes which I've used in the past in terms of trying to help people and starting to form a value-based approach to contracting. And there's three questions that I would normally ask people before we start off on the journey. And the first one is, well, we need to decide what type of contract mechanism should be used. But the first question, if you like, before that is being really clear of what the outcomes are that we want to see. What are the type of outcomes? Well, that's fine. We can start to then see what those outcomes are. What are the available contracting mechanisms? What legally do we have to use? So to give you some examples, if we were working in the Netherlands, if we're working with insurance-based services, there'd be a number of available contracting mechanisms that they've used in terms of collaborative. If you're working in an NHS environment, it's much more limited. There are certain legally prescribed forms of contract you might have to use. And then we would analyse the strengths and weaknesses of those. Are they going to give us the level of collaboration we're after? Do they cover all the relevant providers? Are they going to enable us to incentivize and change the financial structure into a different way? Second question is then, well, what are we contracting for here? So is it going to be outcomes, just activity processes, or some kind of combination across? And then how big should be the size of the bundle that we're looking to incentivize for value? Because that becomes quite a key question when we get later on in terms of, well, what is it going to take to incentivize people? We've seen contracts that have had 1-2% being put onto outcomes, patient-reported outcomes in the NHS for over 10 years. But the common accepted point of that is it didn't really incentivize very much difference. It was seen as very much a tick box exercise. It didn't really incentivize any great change in providers' behavior. So considering how large should the value-based bundle be is a really important question. in a lot of areas with at the moment looking at 10-15% going on outcomes to begin with, potentially with that ramping up as we get better data, better benchmarking. Third question is then, well, what is the incentive mechanism to use? And this is where you can start talking around carrots and sticks, and where we start to think around how is this going to work in practice. Now, budget allocation, attributing weights percentages to different outcomes. One of the first outcome and value-based contracts that I did, they tried to put in around 120 different measurements. And what we ended up getting to was that each of the measurements had such a small weight and percentage value attached to it that it meant that the providers just didn't really understand what the payer was actually looking to achieve from it. And it effectively diffused, if you like, the impact of the value-based approach. So being really clear around those and attributing appropriate weights and percentages is actually very important as well. And then the incentive mechanisms, penalties versus incentives.
Rob, I think we've lost your microphone. Hi all, we seem to have lost Rob's microphone. I'll just see what we can do to try to bring that back. No, we do have a premium version. Thanks for that suggestion. Our link definitely hasn't run out. We're still live. Just trying to figure out what's happened to Rob. I think Rob's just going to try to redial in. If you can just bear with us while we deal with our technical difficulties, we should have us back up and live, hopefully, momentarily. Well, thanks so much for making technology work despite the electricity going out, Rob.
I'm trying my best. It's right. So what I'll try and do is I'll try and share, see if the sharing still works. Apologies, everyone. Apologies for this. But what I will try and do now is, can you see my screen?
We can see your screen.
Yeah, I've just been informed it's an outage in the whole area around. Right. Can you see the screen or my presenter view? Can you, just to check?
We can see your presentation view at the moment.
All right, okay, so that's fine. I'll just take it off that and go just to game-breaking performance to deliver real value. And decided that they wanted to actually put more money in the pot. If the providers could come together and deliver a better value approach, they were prepared to actually reward them for having done so. So that's quite important in terms of looking at the different incentives. Now, the main system, now payment by results is the main system for the NHS. Effectively, every patient seen and treated, if they go into an acute hospital, would tend to be treated and paid for under payment by results, taking a currency, effectively what they call a healthcare resource group. Now, this has been based on the average cost of services reported by NHS providers for each procedure that's been gone through. And what has happened as a result of that is it's created some perverse incentives in the system which haven't really worked towards a value-based way of working. So effectively, it's generated a point where providers are incentivized to getting more and more patients in and generating more and more activity, rather than being rewarded more in terms of outcomes and looking in terms of whether the right place for the patient would necessarily be within an acute setting. So what we've started to see within the NHS, and this is a dynamic I've seen in other international environments as well, is you've started to see a move away from payment by results, payment for activity, into an approach where people are saying, well, actually, we don't want to be incentivizing our providers to work that way. We need to work in a different way across a different number of providers. So moving away to different incentivization methods to actually move towards more pay. Saw, I suppose, mainly with this was it wasn't consistent across.
We're just having you break up a bit there, Rob. I don't know if this is something, is there somewhere else that your mobile can get better reception?
I must be breaking up as well there.
Yeah, we've just lost you for a little bit there.
Apologies. Where did you lose me, Lisa?
I think we lost you just towards the end of the last slide.
Okay. So, well, the point I'm effectively making is that what we're seeing both in England and internationally is a move away from payment for results or payment for activity type models in contracts into models which are building more around patient-defined outcomes, building different incentives in, but the important point being that it needs to be consistent. One of the problems that we've seen recently as in the NHS is that there's a number of different payment incentive models. So we've had some parts of the system being paid for results on activity, some parts being paid on a block basis, effectively having a block of income being given for whatever the services are potentially, and then some being paid on different types of outcomes. So you've got conflicting outcomes which create a confusing incentive, if you like, across a healthcare system. So one of the things we would always start looking at is, well, making sure that you can try with the contracting model to actually start to incentivize the type of activity that you want to move to that more value-based model. So these are the three key factors that we would push people towards thinking around right at the outset, which are, firstly, how can you have clarity on the scope of the pathway and equipment to be included? So, for example, when we were doing the contract work with NHS Wales, when you started looking at cataracts, we looked at that from a value-based perspective and thought it'd be relatively straightforward and simple. But when you start looking at it in more detail, you think, well, is it just the machines, the phaco machines which insert the lenses in people's eyes? Is it the lenses, the antibiotic drops? Is that the scope of what we want to actually deal with? Or is it actually the skills of the surgeon? Is it the actual venue? And it turned out that there were a number of other factors which had a massive impact upon the value for that service. So being really clear from the outset as to what's going to impact on the outcomes and who should be involved in your project is really, really important. And then once you've done that, you've determined which contracts are impacted. Those contracts may well be with different providers. There may well be a need for different providers to start coming together and collaborate. And that means that you're looking to a different type of approach potentially in a contract. How are you going to get those contracts aligned? Do you need to terminate one of them so that you can bring them together? All of those considerations need to be taken into account in terms of the timing and the issues of how you introduce that. And then that third point, how much are we going to tie to these required outcomes and how is the rest reimbursed? What we have seen in a number of instances is a real fear from certain providers of moving to a value-based approach in terms of the uncertainty then that they see as to how they're going to be remunerated, what they're actually going to get at the end of the day out of the contract. So being really clear around how much should be tied into the outcomes to achieve the value, and then do we still need to have inputs and processes in most of the contracts that we've done for value? I would say yes is the answer to that. And the question is how you balance the value part, the patient reported outcomes part against the other elements. And I mentioned earlier a figure of around 15%. That's where most of the systems we're working with at the moment tend to start from, is around that percentage, whilst they're looking at how you incentivize the values and whether you've got the right level. So what do we then see in terms of the different approaches to value-based healthcare? Now, hopefully you can see this slide, hopefully you can still hear me. But what we've actually seen is internationally, they value-based approaches start from light touch, but they move into the more truly transformational. Now, if you start off from the light touch, when you're looking at patients with existing services, individual providers potentially deciding they want to work on a value-based approach, so areas like Martini Clinic, you could say, in Germany, or the Mayo Clinic in the US, linking it into those small areas or individual services, so Martini Clinic being one of the international leaders in prostate cancer treatment. So how do you measure performance or pay for that? So they effectively have worked to a much more value-based approach in terms of how they're working internally. It may not then require collaboration for them to go to other parties and to work with other providers, but what they do then is implement a value-based approach around their own contract with their own payers, with their own commissioners. You then start moving into different groups. Now, these different groups can be across a disease cohort, a pathway. What we've seen internationally is people tend to focus around stroke, MSK, musculoskeletal services, diabetes, looking at that wider pathway of provision from primary community provision through to an acute hospital. That's more complex and more collaborative, requires more providers to work together, more commissioners potentially to come together with their funding, and common outcomes across those pathways of care with linked finances under the contracts. And I'll give you an example in a moment of how we've done that previously in a London-based project. And the final side is really that transformational side, looking at that population-wide approach for value. So this is akin to some of the accountable care organization approaches that we've seen in the US, targeting a specific population, targeting a system. So you can look at examples such as the Blue Cross Blue Shield alternative incentive contract in Massachusetts for this, or in the UK, some of our integrated care provider contracts that have started to come. So how would you actually contract for a capitated budget, for a pound per head of population budget, looking at the outcomes you want and looking at the value that you want to get out from that contract, potentially a single contract with an accountable provider for a whole budget of care. So then, how would you do that across a pathway? I said earlier on that last slide that it's quite complex as to how you would do this. This is an example of a project we did in London whereby, because of the way that the system worked, we were looking at diabetes in this particular example. And if you look at the grey boxes on the slide, the grey boxes will show you that what we did is that each of these providers had a large contract for a whole raft of different services. They didn't have particular diabetes related services. So in order to actually assess diabetes correctly, they effectively carved out the diabetes elements of their services and kept it separate, if you like, into a separate contract. But what we wanted to do was actually to align these providers together rather than having been 4 siloed providers. We wanted them to work together more collaboratively. So we effectively had a single overarching contract which they all signed up to, which had the common outcomes for each of the providers. There was risk share, gain share across those providers in terms of achieving those outcomes in respect to the diabetes service for a particular population, particular segment of northwest London in this instance. So there was an additional contract entered into, but you can see if you start doing it across a pathway, unless you've been contracting that way previously, it can involve a degree of reworking and a degree of changing things.
Rob, quick question on that. If you're talking about such different service providers from such different areas, what are some of the ways that you actually work to get those different groups to agree to a single contract?
It can depend, and in some instances we've had, and the Lambeth example is quite a good one, is people come together to try and fix a common problem. So if you spot, as they did in Lambeth, there was a particular issue around people with severe mental health and learning disabilities issues, and they had mortality rates were very high. They tended to fall between services. And so those organisations effectively came together themselves in a coffee shop and said, we need to do something to change this. So it can be that there's a common problem to fix. In some areas, we've seen national bodies, so NHS England, come and say to people, we need to commission these services differently. So the payer, if you like, Lisa, can take a different approach and can try and push those different groups together. And I think it can be a combination of those. I think there's an increasing group population of people who can see that the current contracting mechanisms aren't really delivering good patient outcomes. And once providers get this picked out to them, and it tends to be actually in some areas the clinicians in those organisations who have it pointed out, who will be pointing it out to the chief executives and others and saying, we're not delivering the best possible services here. The connection between these services isn't right. The outcomes that we're getting are not right. And the more that we look at the outcomes and the more we're seeing measurement of outcomes, the more we're seeing that actually does drive then behaviours of organisations to work together more collaboratively. Because we have, in many countries, had previous siloed type approach where organisation or a hospital will just look internally at itself and at its own sustainability rather than looking at the wider system. The drive when we start getting into these types of models is looking at the patient, looking at the wider sustainability of systems, and actually coming together and working more collaboratively is a much better way of actually doing that.
Thanks, Rob. And we've got a question from Mohammed who is asking, in these cases you're talking about, what's the value, the dollars size of these sort of contracts?
It varies because if you look at the slide I said where you had the light touch right the way up to transformational, some of the contracts we've done, the more transformational ones, I mean, there was one we did which was around £800 million, which I don't know how easily that would translate into Australian dollars, but we're talking significant amounts of healthcare budgets being put onto those. If we look at the Lambeth example here, that was originally one for around 30 or 40 million pounds to start with per year, but that has then subsequently been increased to work across an entire healthcare, mental health care system. So it's effectively times 10, it's around 200, 300 million pounds a year worth of services that are moving under it. So what I would say is it depends, but it can go right the way up to a full population-based approach. So you could start looking effectively at contracts of $1 billion plus for these types of approaches. But the question I would go back with then is, well, how much are we going to put at risk, if you like, on meeting these outcomes? How much are we going to incentivize on outcomes? Because it wouldn't normally be the full value of that contract, Lisa. What you'd be looking at would be, say, 15, 25, 30% of that contract value being incentivized on a more value-based way to create that push for people to operate in a different way.
Thank you.
Okay. So I think this is actually, I mean, I feel it's a bit interesting offering this one to people in Australia, because alliance contracting, in terms of using it in the public sector, really came from Australia and New Zealand. And if you like, people in Europe and the NHS have looked at what you were doing around some of your public sector contracting, have borrowed it, adapted it, and are using it in these types of ways. So what we're seeing in a number of areas is alliance contracts, basically a collaborative contract based upon principles, based upon governance across different organisations, and common outcomes being entered into by all of these different providers. You may have separate contracts, but there's an overarching alliance, which is a glue which brings together each of those individual providers. And that brings me on to Lambeth, which is they adopted an alliance approach. Effectively, as I've mentioned in response to one of the previous questions, they had some huge issues in terms of their people with severe mental health and learning disabilities, people falling between the cracks, if you like, of the system there, and effectively being lost to the system, people living on the streets, people dying far too early. There was a real issue across Lambeth, and they decided to come together through the chief executives actually meeting and realising that the outcomes that they were getting really appalling for this particular part of the population. And so what they decided was they had to radically improve the outcomes, within a context of reduced expenditure, because effectively the funding for this area wasn't increasing and it wasn't likely to increase. They needed to do something different. So what they pulled together were their three big outcomes here. Now these outcomes, effectively to recover and stay well, people to be allowed to make their own choices and participate on an equal footing in daily life. There's a number of sub-factors that fit underneath those, but those are the three key outcomes, if you like, they were enumerating against. As I said earlier, they also built more of an incentive mechanism on those as well. So when they could actually show as providers they'd managed to beat those, but actually beat them by 20, 30% to radically improve them in, if you like, game-changing performance, there would be an additional incentive that would then be given to the providers from the local authority and from the NHS to actually pay for that service and to reward them for exceptional performance. And these are the different providers they had. The collaborative was quite an interesting group because it included primary care, included service users, carers, social care. So they brought together a whole raft of different organisations to work in this way. And what it effectively delivered was more of, if you're thinking around the work of Michael Porter in Value, it was more of the MDC. It's a multidisciplinary team working really closely together, coordinated support and services to communities, multi-agency support for people with severe enduring mental health problems to assess the funding, and that linking in then to NHS services around mental health so that people weren't just pushed straight into the acute beds in the trust, but actually they were supported more around the community by voluntary sector, by charity organisations as well, linking up all the support that was available to work in a very different way. And they used an alliance contract as a way of doing this and set out the clear shared principles and values of working as to how they wanted to work together under this in terms of the risk share and gain share that was coming through. And as a result, this last slide on Lambeth is one that came through from the client. I asked the client for, well, what the lessons they had learned from this, because in the first 2 years of this, effectively what they did is they massively improved the outcomes for this particular cohort of service users. But also they found that they were able to do that within a reduced budget. So that actually the cost went down by about 15%, but they delivered much better outcomes. And the things that they were focusing on when they said from working in this way, from working to the more value-based approach, was that the collaborative relationships, having the common vision, having the outcomes, that was massively important to them. They're also working effectively across two different systems at the time. So innovating, taking time to do the value-based while still doing the normal day job as well. So they called it feeding the beast. So you shouldn't underestimate the challenge in terms of the administration and work in moving this way. Developing the outcomes evidence base was challenging because people hadn't been capturing these outcomes in the same way previously. So they were developing the metrics and the data capture at the start of the project, and that was really important. But again, you've got to build that into the start of the move to a value-based approach. And that culture change, working across multiple professional clinical stakeholder interests was really important for them as well. But the final point they made was the power of narrative, which are the stories around the patients. Going back to the earlier questions around how you tie in people, how do you get providers engaged? If you go to the website for Lambeth Linwell Collaborative, there's some fantastic stories about how service users' experiences, how their lives were changed and turned around effectively by how this worked. And that was incredibly powerful for them. And it was so successful that effectively from starting with a small cohort of around 300, 400 patients, they moved it then on to be the way that Lambeth commissioned and delivered all of their mental health services. So
Rob,
with one eye on time, sorry, Lisa, after you.
We've got a couple of questions about Lambeth, where, if you've got a few more minutes that you can share with us. So the first is, how did they put all the funds into one bucket and redistribute? Did they pull them all out of acute into community, or how did that work? And then also, do you have any examples, which you may or may not have, of collaborative clinical governance that happened in that process?
Okay. On the first one, the funding, it was effectively, I mean, the people who commission and pay for the services, it was the clinical commissioning group and local authority. And what they did is they entered into an agreement to pool their funds together to pay for the services. Now, under the alliance, the funding was distributed into accordance with the outcomes and delivery. But in essence, it took the people who were paying the services to say, actually, there's no point us having lots of separate contracts. We want to pool this funding into a different way. So they effectively merged the people who were paying for the services into one. and then the alliance would then deal with them directly. So that's how they started to get that common approach across the funding. Problem we've had many areas internationally is where you've got 2 or 3 different bodies who are responsible for the funding, so insurance and state and different organisations that might be responsible for funding the system. In this particular instance, they were able to bring it together, and that was one of the first things they did around Lambeth, was saying, well, if we're not going to commission and pay for these services in a coordinated way, how can you expect the providers to then be coordinated? In terms of the clinical grouping, I haven't got many examples in terms of Lambeth. I know that they had a common clinical group that they did set up around designing the outcomes. And what we have also seen is that getting the clinicians together, having separate clinical work stream on value projects is an essential starting point to get the clinicians engaged with this. One thing we did do on an earlier project was when we were looking at diabetes, we had patient outcome parties where they invited people with diabetes to come together and actually meet down with clinicians and actually explain their experiences with diabetes and what the outcomes they really wanted. So the clinicians were there having the discussion with the patients, helping to form the outcomes that were going to be incentivized, but actually having the patients there and inputting into the process as well. So there's a number of different ways you can start to get that clinical collaboration into place. Those are just a couple of those. I suppose we can probably go on and go through a few more.
Thanks, Rob.
Okay, I think probably what I'll do is, with an eye to time, I think I'm on my last slide pretty much, Lisa, anyway, and apologies for losing a few minutes due to the power cut. The power is still off here, which is slightly disconcerting. But I think hopefully you'll see from all the different examples that I've given, what we say at the start is, if we want to incentivize value, then we need to be clear around how we're measuring it, and it needs to be attributable to the providers that we're asking to be accountable for it. So, for example, we can't expect people, for a healthcare provider of acute services, to be responsible for increased rates of asthma in a population where they just wouldn't have any control over things such as air pollution. You've got to be focused upon the actual outcomes that you want the providers to be able to deliver, and that's where certainly we use a lot the ICHOM data sets, which are freely available on the ICHOM website, in terms of outcomes for disease groups and for particular conditions, is a very good starting point to start to actually look at what the right outcomes may well be from a clinical perspective. There needs to be a different dynamic if we're moving to a value-based approach between payer, your commissioner of services, and the provider. Moving from that inputs and activity and an almost confrontational approach towards a joint approach of how are we best going to deliver these outcomes, how are we going to get value into the system. And value can be introduced. I think you can see it quite clearly from some of the examples we've given, that you can look at procurement and contracting as a key lever to start to bring value into a system. But it's a mix of factors, including the finance, including how the contracts are set up and how we're measuring it. And you need to start being consistent over time. Lambeth, as an example, they started that work in around 2014, and it's been going now for 5 years. It needs to be consistent over time to start to get the results that you want. And then transparency of data. If we want to actually start to look at where outcomes are actually, there's a disparity in outcomes across the system, if we want to bring that together, and if we want to actually incentivize and share innovation really quickly, having transparency of the outcome data, showing the areas that are really making that game-changing performance. Whilst that's going to be challenging for some systems in the short term, that's going to have long-term benefits in terms of sharing best practice and increasing the value across healthcare systems.
Well, Rob, thank you so much for that presentation. Thank you for persevering through blackouts and technological challenges. We really appreciate it, and I think I can speak for everyone online to say that's been fascinating, huge amounts of food for thought, and I think you've sparked a lot of conversations here about how we can really think about value in procurement. So as I mentioned at the start of this webinar, this is going to be a series of webinars, and the next will be held at the end of July and will focus on consumer engagement. We'll be sending out more information in the coming weeks, but I'd like to thank everyone for joining us, and once again thank Rob and his super efforts of keeping this webinar going despite technology.
Thank you, Lisa. Thank you, everyone.